Yes, guys. So sorry. So there was good evening. Good evening. So there was some issue. So now we have got it rectified. Okay. So let me start with. So welcome. Welcome to this INICT predictor. Yeah. Good evening, everyone. So yes. So I'm having 10 questions. I'm going to expect at least a few questions going to be topics to going to be repeated in this year INICT. Okay, so let me start with question number one. So again, my approach always start with the last line. So what is the most likely diagnosis? That is a question asked to me. Option: subacute degeneration due to B12 deficiency, then hemochromatosis, then subacute degeneration due to diabetes, and plasma cell neoplasm. These are the four options given to me. So let me try to look at four options that are given to me now. Yes, these are the four options given to us. So basically, examiner is expecting what is a likely diagnosis, right? Let me start with the question then. What is the question? A patient presents with hyperpigmented skin lesions. Okay, a patient presented with hyperpigmented skin lesions. Hepatosplenomegaly is also there. Hepatosplenomegaly is there. Polyuria is there. Numbness in the legs is also there. Total proteins are 12 gram per deciliter. Albumin is 3 grams per deciliter. Serum electrophoresis is as shown below. Okay, so important. Let me start looking at it. Okay, patient is having one. Okay, mix and match is the best approach, I would say. Hyperpigmented skin lesion, hepatosplenomegaly, polyuria. This is more suggestive of as you are thinking of. Okay, so yes, then albumin is 3 grams per deciliter. So very good, very good. Yeah, many of you have answered it as option D. Yes, exactly correct. You're right, guys. Option D is the correct answer here. How did you arrive at option D? So let us look at option D. Why option D here? Okay, important keywords that are given to me here are, yes, total protein is increased, understandable. 12 is increased total protein is there. Yes, correct. Total protein is increased. And what about albumin? Albumin is 3, slightly reduced. The rest will be globulin, by the way. So your globulins will be approximately in this 12 minus 3, approximately 9. So globulins are increased here. And anyway, electrophoresis is a keyword here. In electrophoresis, you are seeing a gamma spike, single spike in the gamma region, which is suggestive of monoclonal gammopathy. Monoclonal gammopathy. Okay. Now, important confusing words that were given to us in this question was your polyuria, etc. So, patient, okay. So, is it hemochromatosis? Looks like hemochromatosis because hemochromatosis can have polyuria, etc. But it will not have one spike. Yes, gamma spike that is seen, that is a very key for what? Diagnosis of a plasma cell neoplasm. That is the correct answer. Now, it is not due to B12 deficiency. Keyword here being what? Gamma spike here, right? Yes. So now I want to understand, sir, why is, so basically you are suspecting a plasma cell neoplasm. Why are there hyperpigmented lesion? Why is there hepatosplenomegaly? Why is there numbness in the leg? And why is there polyuria happening? Because typical plasma cell neoplasm do not have these manifestation. So let me try to explain them. The paraneoplastic syndromes. So paraneoplastic syndromes of PNSL, right, of plasma cell neoplasms are important. Plasma cell neoplasm or multiple myeloma, we can say. So important plasma cell neoplasms. One, POEM syndrome. What is a POEM syndrome? POEM syndrome will be polyneuropathy, organomegaly, endocrinopathy, M protein and skin changes will be seen. POEM syndrome. Another condition called Tempe syndrome. Tempe will be telangiectasia, elevated erythropoietin, erythrocytosis, monoclonal gammopathy, perinephric fluid collection, and intrapulmonary shunting happening. And one more, ASOP syndrome. Adenopathy with extensive skin patch overlying plasmacytoma. So these are the important conditions of us paraneoplastic associated with plasma cell neoplasm. So important in this poems and Tempe syndrome expected in exam to come in exam, not directly poem or a Tempe syndrome. Probably they'll end up hiding this in one of the image or in the question, and they will give you. So just it is, do not make polyuria, hepatosplenomegaly, do not make another diagnosis. Even multiple myeloma or plasma cell neoplasms can be having these manifestations, right? Next, question number 2. So I am taking question number 2 now. Which of the following is, yes, correct, one liner question, correct chronological changes in iron deficiency anemia? So what are the correct chronological changes in iron deficiency anemia? Decreased hemoglobin, decreased serum iron, decreased serum ferritin, increased TIBC, increase in RDW. Yes, sir. What will happen first? Okay. Amongst the given, everybody knows the earliest and the most sensitive is what? Serum ferritin. This is the one which will happen first. So answer will be whatever starts with 3. So C is not the correct answer. All others are starting with 3, right? Yes. Then after that, what do I look? After decrease in serum iron, next will be, so second in order will be decrease in serum, first will be serum ferritin, sorry, not decrease in serum iron. After that, there will be increase in TIBC happening. So after 3, it will be 4. So your A is also ruled out. After 3, it will be 4. Then A is also ruled out. Then after that, so when TIBC increases, after that, serum iron will decrease. Serum iron will be decreasing. And then there will be increase in RDW. And then finally, there will be decrease in hemoglobin. So basically, it will be 3, 4, then 2, 5, and 1. Correct. Very good. Answer is option B. Option B is the correct answer. So iron deficiency, iron metabolism. Important to understand in iron deficiency. First will be the first changes of iron deficiency. We call them as what? Yes. The earliest changes of iron deficiency are the, yes. So we can divide the iron deficiency into 3 phases: pre-latent phase, latent phase, and an anemic phase. In anemic phase, what will be the finding? In anemic phase, there will be anemia happening, RDW, RBC changes will happen. In pre-latent phase, there will be decrease in serum ferritin. That's the first thing. Then there will be increase in TIBC. Then there will be decrease in saturation. Then finally, there will be decrease in serum iron. When serum iron decreases, bone marrow gets less iron. Because bone marrow is getting less iron, the erythropoiesis gets affected, and that is why first RBC index to change will be RDW starts increasing. Then after that, MCHC reduces, then MCV reduces, and then okay. So RBC indices changes also we should know. RBC indices changes will be increase in RDW. That is the first thing to happen. After that, decrease in MCHC. After that, decrease in MCV. After that, decrease in MCH. So this can come as a 2 way of asking question. Increase RDW is non-specific. That is why which RBC index will help us to make a diagnosis. So for diagnosis, RBC index will be MCHC. Very, very sensitive, and early changes will happen with MCHC. Although RDW happens before, but it is not specific. Increased RDW can be seen in many other conditions as well, right? Next, question number 3. 2-deoxy-D-glucose or 2DG. It looks more like a pharmacology question, by the way. 2DG. So what about this 2DG here? 2DG is used in treatment of cancer. Acts by what? So they are asking you what is the mechanism of action of a 2DG. So what is this 2DG? 2-deoxy-D-glucose. Uses, one, it is used in anti-cancer, correct? It was even tried in COVID. Not very successful. But yes, in severe COVID, this was tried. 2DG. So what is the mechanism of action of 2-deoxy-D-glucose? So basically look at this. This is a glucose molecule. Yes, correct. This is a glucose molecule. Important, 2-deoxy-D-glucose. Yes, it cannot be metabolized by human cells. It cannot be metabolized by human cells. So if it cannot be metabolized by human cells, the problem is if you take up 2-deoxy-D-glucose, when the glucose enters into your cell cannot undergo what? Glycolysis. So basically, yes, correct answer is option D, inhibits glycolysis. But how it work in cancer cell? Why will it not kill normal cell? It can kill normal cell also. But remember, due to Warburg effect, so if I inject 2-deoxy-D-glucose, tell me which cells will take up more of this glucose. This is like a glucose molecule. Which cells will take up more glucose? Cancer cells will be taking more glucose. Why? Because of Warburg effect. Because they take up more glucose, but none of these glucose molecules are going to be what? Metabolized. Thus, cancer cell, which was dependent heavily only on what? Glycolysis for its ATP, and that is not going to be happening, and that is why you'll end up having a death. So same thing even in COVID also. Why in COVID? Because even Warburg effect will happen in cells infected by the virus as well, because viral DNA has to replicate, and for that replication you need to undergo again Warburg effect. Any replicating cells can be showing Warburg effect, right? Yes, so that is a mechanism. Next, okay, arrest of a cell cycle in G1S. So when will this happen? Arrest of cell cycle in G1S. Your RB should remain hypophosphorylated. Then only they will be there, right? Induce apoptosis, many things. Allows activation of T cells, the CTLA4, ipilimumab, etc., which are antibodies to CTLA4. That will be option C. Next, question number 4. Question number 4, let me see, look at this question now. What is this question? Last line, because it's a lengthy one. What mutation is likely to be seen in this patient? Option 13q deletion, BRAF mutation, 922, 1517. There are two ways to approach this. One is try to write what mutations are, yes, what mutations are seen. Okay, sorry, I have missed out on the image here. Okay, so sorry. Yeah, sorry. Yes, so somehow that image has missed, or it might be in the last page. Let me just check. No, it is not there. Sorry guys. So basically, anyway, let me check in this. Actually, I had given a cell with hair-like projections. So this was the image that was given to us. Okay, assume this was the image. Somehow it has got messed up. I'll just try to add that image here. Let me just check. Okay, so yes, cells with hair-like projection, hairy cell. That was the image that I had added. Anyway, so yes, tell me now. So in hairy cell, what mutation do you get? In hairy cell, what mutation do you get? Answer is option B. 13q deletion will be seen in CLL. T922 will be seen in CML. 1517 will be seen in AMLM3. Okay. So this was yeah, CLL image, which somehow I missed that image now. So CLL image was supposed to be given here. Anyway, I will be adding the CLL image when I'm going to give the annotated PDF of this. Okay. Yes. Next, question number 5. Question number 5. Okay, look at this last line. Let me start with last line. Which mutation is most likely cause it? ADA, 22q11 deletion, IL-2 receptor, BTK mutation. Okay, so looking at the options, I can think and tell. I am suspecting what? ADA will be SCID. 22q11 deletion will be Dijot syndrome. IL-2 receptor will be SCID, and BTK. All are immunodeficiency disorders, right? Yes, let me see the question. 6-month-old child presents with recurrent infection. Is it a keyword? No, it is not a keyword. Why? Because all immunodeficiencies will have what? Recurrent infection. Imaging shows spleen is shrunken. The moment spleen is shrunken, I will definitely think there is what? There is a problem with humoral. Humoral deficiency is for sure there. Either humoral deficiency, or I can write one more, combined immunodeficiency. Right? Either humoral or combined immunodeficiency. So this is what I'll be suspecting at the beginning here, right? Either humoral or combined. Next, blood examination shows absent B, absent T. So now my diagnosis is not humoral. My diagnosis is definitely what? Combined immunodeficiency. And decrease in IgG, A and M, that is also making a diagnosis of combined immunodeficiency. So what is the most likely mutation to cause it? So it is not option A. So not option B. Option B, because it is a Dijot syndrome, right? Dijot will not be. BTK is also not the answer. This is your Bruton's. Bruton will be purely humoral immunodeficiency. ADA deficiency is also SCID, SCID. IL-2 receptor, or also called gamma chain receptor, is also SCID mutation. So answer, most likely mutation will be IL-2 receptor. 70% of cases of SCID are due to IL-2 receptor, 30% are due to ADA deficiency. And SCID receptor mutation or IL-2 receptor is a X-linked recessive, ADA is a autosomal recessive condition. So in this case, answer will not be ADA, answer will be IL-2 receptor, also called as IL-2 receptor. Another name is gamma chain receptor. Gamma chain receptor mutation. There is a gamma chain receptor mutation. So answer is option C here. Okay. Next, question number 6. So all immunodeficiencies, very important. Immunodeficiencies are very important. Pure humoral immunodeficiencies, Bruton, BTK, will have all immunoglobulin reduced. B cells will be less, not T cells. T cells will be normal. If it is a Dye-George syndrome, tell me now what Dye-George will be having what? Absent thymus, and patient will have hypocalcemic tetany seizures, cleft palate, cleft lip, etc. will be there, right? Yes, ADA and IL-2 receptor, both of them will lead to SCID. What is the treatment for this condition? Treatment for this condition is allogenic hematopoietic stem cell transplant. That is a treatment for this condition, right? So apart from this, others will be hyper IgM syndrome, where there is more IgM and less of IgG and IgA, and one more isolated IgA deficiency, right? These are the various immunodeficiency disorders. So keyword very important in this. If I write absent thymic shadow is present, then also answer still remains SCID. Okay, because okay, so in SCID, one important thing, primarily absent thymic shadow is in Dye-George, whereas in SCID there is a secondary absence of thymic shadow, right? Treatment will be, yes, correct, allogenic HSCT. That is a treatment of choice, and it should be early. Why? Because this is a very severe disease. Usually most of them die during infancy. Treatment will be allogenic hematopoietic stem cell transplantation, right? Next, question number 6. Question number 6, let us look at this last line again. Yes, sir. What is the last line? You start suspecting a genetic cause, which is a most likely etiology. Which is most likely to be the etiology in this? Option given: TSC, von Hippel-Lindau, fumarate dehydratase, Li-Fraumeni syndrome. TSC causes what? Just to know. Yes, tell me. TSC causes tuberous sclerosis, isn't it? Tuberous sclerosis. Von Hippel-Lindau syndrome, VHL syndrome. Tuberous sclerosis will have SEGA. What is SEGA? Subependymal giant cell astrocytoma. Cortical tubers will be there. Angiomyolipomas will be there. AML of kidney will be there, right? Von Hippel-Lindau will have CRCC, cerebellar hemangioblastomas, and polycythemia. Fumarate dehydratase mutation, FD mutation, this will lead to CRCC, multiple leiomyomas. So multiple leiomyomas and ovarian tumors. Usually a sex cord stromal tumor of the ovaries can be seen. Li-Fraumeni syndrome, multiple cancers, usually leukemias, sarcoma, brain tumor, common ones. Any tumor can be happening here, right? And brain tumor. So these are the diseases that we are talking. So let me see the question, which one is fitting into which one in this. Okay, 25-year female presents with thrombosis and weight loss. So she's having thrombosis, weight loss. Blood examination, hemoglobin 17. So is it a keyword for me? Yes, absolutely. Why? 17 hemoglobin, polycythemia. The moment I suspect this is a polycythemia. Okay, TLC is 4000. TLC is 4000. Platelet count 1 lakh. So polycythemia, okay, platelet 1 lakh. Imaging suggests there's a mass in her brain. Okay, mass in her brain. Further, her father died of renal cancer a few years ago. So answer is option B. Remember, even tuberous sclerosis will also have a mass in the brain, remember, but it will have a angiomyolipoma of kidney and it will not have a polycythemia. So in this keyword is polycythemia. Angiomyolipoma of kidney is a benign tumor of the kidney, not malignant tumor. Question has been reported that father died of what? Renal cancer. Yes, Leaf-Romani syndrome is P53 mutation. That is a P53 mutation, right? Next. So this is about your important RCCs. Clear cell RCCs can be associated with two of them, von Hippel-Lindau and a fumarate dehydratase mutation. FD we call it. Clear cell, there will be what? CRCCs, leiomyomas. Leiomyomas in, what are leiomyomas? Nothing but what? Smooth muscle tumor in skin and in uterus. Basically multiple fibroid, yes, will be seen. And yes, lymphangiomyomatosis will be seen in tuberous sclerosis. Cortical tubers will be there. Sjogren patches can be there. SEGA, subependymal giant cell astrocytoma, angiomyolipoma of kidney, lymphangiomyomatosis can be seen in tuberous sclerosis, right? Yes. Next, question number 7. Let us look at this question now. Okay, question number 7. Again, it is a chronological order. Correct chronological order of activity in the wound healing. So they're asking what is the correct chronological order of activity in the wound healing. Neutrophils, blood vessel proliferation, maximum strength, fibroblast proliferation, platelets. Okay, so in this, what will be the first one to arrive? So let me start. First will be what? Platelets in this, right? First one will be the platelets. Okay, so 5 should be 1. Okay, B and D are ruled out. B and D are ruled out. Next. No, not B, sir. First will not be neutrophils. First one will be what? Platelet. Next will be neutrophil. After 5, it should be 1. Okay, both of them are 1. Then both of them contain 2 only. What is that? Blood vessel proliferation. That will be. Then maximum strength or fibroblast proliferation, which will happen before. Maximum strength will be the last one. Fibroblast proliferation and maximum strength. So basically it will be 5, then 1, then 2, then 4, then 3. Yes, correct. Option A is the correct answer here. 7, option A. Maximum strength will be, when will maximum strength be? Tell me now. Maximum strength will be 3 months. Fibroblast proliferation starts between 5 to 7 days. Neutrophil between, okay, 1 to 3 days. Or 1 day you can say neutrophil. 1 day. Platelets, few hours to less than 1 day. But it will be less than 24 hours platelets. Okay. Yes. So these are the different phases of, maximum strength. When will maximum collagen be present? 3 weeks. That also can be added here. Maximum collagen, 3 weeks. Fibroblast proliferation starts at 5 to 7 days. Maximum fibrosis will be at 3 weeks. Okay. Next, question number 8. Yes. So let me look at this. What is this question? Up last line again. I would start. Which of the following, okay, statements are true about the disease? Okay, multiple true false type of question. Don't start with last line. Start with the diagnosis, because for multiple true you have to make a diagnosis. A patient presents with thrombosis and dark colored urine. What are you suspecting? A thrombosis is there and dark colored. Dark colored urine is suggestive of hemoglobinuria, isn't it? Dark urine is suggestive of HBurea, right? Hemoglobinuria and thrombosis. So there is thrombosis, hemoglobinuria. What are you suspecting? I am suspecting query PNH. Classical triad will be thrombosis, thrombocytopenia and hemoglobinuria, right? 2 of them have been given. Hemoglobin is 10, that is reduced. MC is 27, 26, 75, red T count 6. Okay, so my diagnosis of PNH is correct. Yes, it is PNH. So which of the following statements are true has been asked. So true has been asked. Ham's test is positive but not diagnostic. Okay, so all of them are having 1. So I need not break my head over 1 here. See, all of them are having 1. I need not break my head over 1. And all of them are having 1. 3 also, I need not break my head over 3. So 1 and 3 have to be true in this. Examiner only has given. Look, sometimes multiple true false type become very easy. 1 and 3 have to be true. Why? Because all of them are having 1 and 3. Okay, now next I need to only know one, 2 and 4 then. Because two options are having 2 option and 4 is also there. Let me check what is 2. So yes, option 2, true or false. Inherited mutation of PIGA in the stem cells. True, false? Yes, sir. This is a false statement. Very good. Why false? It is not inherited. It is acquired, not inherited mutation. So this is false. So 2 is false. So this cannot be the answer. This cannot be the answer. So now 1, 3 or 1, 3 and 4. 1, 3 or 1, 3 and 4. Yes, tell me now. So many of you have answered it as 8C. Some of you have answered it as 8A. Okay, let us check now. 4. CD55-59 positivity is diagnostic. This is a false statement. Not positivity. There should be what? Negative CD55 and 59. Because there is a deficiency of 55 and 59. They should be negative, not positive. So 4 is also false. So answer is option A. Very good. So few of you have got it. Option A is the correct answer here, right? 1 and 3 are true. So even C is false, right? C is also false here. Yes. So PNH. What is the treatment of PNH? Treatment of PNH. One, we can give eculizumab and ravulizumab and allogenic HSCT. Okay, so Ham's test, yes, it is positive but not diagnostic. Even you can do a sucrose lysis test also. Diagnostic investigation is flow cytometry. There should be absence of CD55 and 59, not positive, right? Yes. Allogenic hematopoietic stem cell transplant. That will be the treatment here. Complications of PNH, just to understand complications of PNH. Complication 1 frequently causes what? Aplastic anemia and even can progress to AML. So this is frequent complication. AML progression is a rare complication of PNH. Complications of PNH, right? Yes. And PNH is autoimmune or non-autoimmune? It is not an autoimmune condition. PNH is not autoimmune because there is a mutation here. It is. So Coombs test will be negative in PNH. Next. Right? Yes. Next is a histological examination of a myocardial biopsy is as follows. What is a likely diagnosis? So this is a one-liner. So you should be able to diagnose based on the morphology only. Nothing else has been told to us. So this is a biopsy from the muscle, myocardium, and what is a likely diagnosis? So whenever you do not have any much history given, mix and match. Keep checking. A is true or false, B is true or false, C is true or false, or D. Okay, let me start with D. Is it amyloidosis? Answer is no. I don't see any pink extracellular material being deposited. These are not extracellular material. These are what? Myocardial fibers. Extracellular, no material is there. So B is false. MI after 3 to 4 days. That is also false because MI after 3 to 4 days would be having dense neutrophilic infiltrate. So I am not seeing dense neutrophilic infiltrate here. That is also false. Reperfusion injury, hypertrophic cardiomyopathy. In hypertrophic, I should see boxcar nuclei. Boxcar nuclei, that is very characteristic. Even you can see myocyte disarray. In reperfusion, you should be seeing contraction band necrosis. So what is a contraction band necrosis? Okay, I can identify definitely there is a necrosis in this image here. So can you identify necrosis here? Look, all these cells myocardium are necrotic. Why? Because I don't see any nucleus. There is a karyolysis that has happened. So there is a karyolysis everywhere. That is why all these are what? Necrotic nuclei. Correct? Yes. In addition, look at these hypereosinophilic bands. The double arrows that I am pointing now, these double arrows are pointing to what? Hypereosinophilic bands, and these are the one which we call them contraction bands. So these are your contraction bands. With the double arrow that I have labeled, these are contraction band. Why is contraction band happening? They can ask you this. Mechanism of such a contraction band is due to increased calcium. Whenever you reperfuse a hypoxic tissue, more calcium reaches the site, and when more calcium reaches, that induces a contraction, and this is a contraction band necrosis, very characteristic of reperfusion injury. Correct, that is the correct answer here, option B, not option A, reperfusion injury, right? Next, the last question. Let us look at this last question now. What is the question asked? Which of the following is the most likely cause? So they have asked again cause or diagnosis, right? Most likely diagnosis, option FSGS, PSGN, IgA, lupus. Okay, so let me start. Child presents with recurrent hematuria. The moment I am thinking they have given me a history of child, it is unlikely to be FSGS, unlikely to be lupus. Why? Both of them occur in adult. Lupus definitely in adult, autoimmune condition, not in child. FSGS is the most common cause of nephrotic syndrome in adults, isn't it? So unlikely to be these two. Anyway, after bouts of respiratory tract infection, urine examination shows RBC and RBC cast. So this is suggestive of a acute nephritic syndrome. Acute nephritic syndrome. That is why definitely not A now. Definitely not A. FSGS will present with nephrotic syndrome. Nephrotic syndrome. Yes, sir. How many of you answered it PSGN here? How many of you think PSGN is the correct answer? Image also has been given to us. Okay, more important, whatever is the image showing, most importantly word, you have missed out a keyword here. Which keyword did you miss out? Let me say recurrent is the word happening. So patient is having a recurrent hematuria after bouts of respiratory tract infection. It cannot be PSGN. PSGN does not recur. Yes, very good. Answer is option C, IgA nephropathy. Anyway, image was okay. Whether whatever image has been given, not given, doesn't matter. The answer will remain what? Same, IgA nephropathy. In the image, what you are seeing is a mesangial expansion. And I accept this many a times just based on the image at your level, you'll not be able to make a diagnosis. So there is a mesangial expansion happening. Mesangial expansion is happening. So you might not be, because PSGN also somewhat appears very similar. Only difference will be there will be more luminal cells. There will be endocapillary proliferation. There will be multiple lumen within them. Okay. So even without that also, I would have made a diagnosis of IgA nephropathy because it is recurrent. Okay. So please be very careful with what examiner is asking you. So yes, nowadays examiners have to keep twisting the questions for you rather than, just giving the straightforward questions. So they will always be twisting the questions. So these were your most important topics I have covered from pathology. Let me just tell you, for INICET or AIMS people, usually they have a more skewed hematology paper. So it will be all or none phenomena again. Either there will be too many WBC questions or too many RBC questions, and or maybe in one session there will be too many WBC and then another session there will be too many RBC questions. So make sure read RBC, WBC topics very well. All anemias you should be knowing. WBC, all leukemias, all leukemia treatment, all leukemia diagnostic guidelines, which we already have discussed in the class. You have to know them. And then about anemias, iron deficiency, B12, folate, for sure. IDA with DDs, B12 and folate. These are for sure. And sickle, thalassemia, two more important anemias, and PNH. So 6 anemias you should be knowing very well for INICET. Okay. Yes, any doubts if you are having, please put forward. Okay, guys. So I will end the session then. Okay. So best wishes, guys. Just go express yourself. Start with the last line and the option. Then everything becomes easy for you. Okay.